everybody. It is so exciting to see the names of old friends and to see new friends coming to join us for this incredible webinar. I am thrilled and honored to be able to introduce this duo to you. I first had the opportunity to meet them when they came to one of our full 5-day EBP immersions, and it has been an honor, and I have been in awe as I've watched them take the information that they've learned, take it back to their organization, and really leverage academic practice partnerships to bring this work to life and to really elevate and enrich what's going on, not just at Westchester Hospital, but at the university as well. So without further ado, allow me to introduce our two presenters for today. So first, Cindy Brockway. Cindy is the Director of Research and Disease Management at Penn Medicine Chester County Hospital. In this role, she provides oversight of entity-wide clinical research studies. Her passion really is mentoring and coaching nurses in the conduct of research and providing leadership and support and incorporating evidence into practice. Cindy earned a Master of Science degree at the University of Delaware in Acute Care CNS program and a Bachelor of Science in Nursing at Michigan State University. She's a certified clinical research professional and recently became an EBP facilitator and co-facilitator through through the Fold Institute, where she is one of our facilitators. Our second presenter, co-presenting with Cindy, is Cheryl Monturo. Cheryl is a professor of nursing at Westchester University of Pennsylvania and a senior nurse scientist for Penn Medicine at Chester County Hospital in Westchester, Pennsylvania, which is in eastern PA. She earned a PhD from the University of Pennsylvania School of Nursing, master's degree and postmaster's certificate in nursing, and a master's degree in bioethics from the University of Pennsylvania Schools of Nursing and Medicine, Philly, and a Bachelor of Science in Nursing from William Patterson University in Wayne, New Jersey. So she is a Jersey girl as well. She completed a Hartford Claire M. Fagan postdoctoral fellowship at the University of Pennsylvania in cooperation with the VA in Philadelphia. She recently became an EBP facilitator and co-facilitator through the Fold Institute here at Ohio State. Her program of research focuses on bioethical issues related to palliative and hospice care in older adults. Cheryl authored and co-authored more than 20 peer-reviewed articles and book chapters, lectures locally and nationally on her research interests and services on local and national ethics and advisory boards and panels, such as a nurse bioethicist. Dr. Monturo is the recipient of both pre- and postdoctoral national scholarships. So without further ado, I'm going to turn it over to our incredible presenters so that they can share their story of really leveraging academic practice partnerships to bring evidence-based practice to life. So take it away, ladies.
Cindy, thank you so much for that lovely introduction. We appreciate it. So I'm Cindy Brockway, and I want to tell you a little bit about Chester County Hospital. It was chartered in 1892 as a 10-bed dispensary, and the hospital has been serving Chester County and its surrounding communities for over 127 years. It's located in Westchester, Pennsylvania, and it has 243 inpatient beds. We've been going through a lot of changes in the past several years. In 2013, we joined the University of Pennsylvania Health System, and right now we're undergoing a major construction project with opening a new pavilion and a platform next January. I've been a nurse for over 40 years. I started when I was 2 years old, and have had a variety of different experiences that I have really enjoyed, as you can see. I'm currently the Director of Research and have been in that position for 12 years.
And thank you again, Cindy, for your introduction. This is Cheryl Monturo, and Cindy Zelfer did a great job of introducing me. Just to give you a little bit background, a way to balance my research and my teaching. When I joined Westchester University about 15 years ago, my dean said to me, "How do I support your research?" And I said to him, "Build me a hospital." And so 15 years later, that didn't happen. But what did happen is the partnership between Westchester University and Chester County Hospital that supports my current role. And we've accomplished so much, and we'll look forward to accomplishing more in the years to come. Cindy Brockway and I come at the issue of research and EBP from different perspectives. Cindy from a clinical and administrative view, and I from a clinical and an academic view. But together we've embarked on this journey that includes a very broad 360-degree view of the issues of EBP and research, making our partnership so very valuable. So the objectives we have up on the screen are the ones that were in the announcement when it came out, and so they're pretty broad. What we want to speak to are three of these. The first one being the current information in the field of EBP in terms of the literature as well as from the Fold. We'll also show you how we connected initially with the Fold Institute, and we remain very connected. And then finally, we'll share our journey, our progress, and our successes in EBP and research.
So let's start with the beginning of research. So the history of research program here at Chester County Hospital has been one of being interdisciplinary and interprofessional. And as Director of Research, many relationships have already been developed over time, and you'll hear that mentioned throughout our webinar here. The driver and originator of the research studies here was led by the medical director of the oncology program back in the late 80s. So that was over 30 years ago. He took the initiative to want to bring oncology studies to our patients here in the community. And medical oncology continues to be the largest component of our research program. We have conducted some industry-sponsored studies within cardiology and oncology, but we find them very resource-intensive with our very limited research staff. We have investigator-initiated studies that is growing and continues to grow, the largest one being nursing and medicine and pharmacy.
And a point that I want to make that we found over our time with our relationship with the Fold is that different from a lot of our colleagues where directors of research were directors of nursing research, Cindy is director of research for the entire institution, so everything falls under that. So it's a very interprofessional collaboration.
So research in our magnet journey. We had our initial site visit on September of 2014. And the bad news is that we heard nursing research was the weakest link. Now, as director of research, that's when one hopes the earth opens up and instantly swallows me, but that didn't happen. But what they said is, you're okay for now. And the good news is that you need organizational support of additional resources required to meet future magnet standards. The initial designation followed in November of 2014, and several years earlier, CCH nursing leaders had developed a positive relationship with Westchester University professor Cheryl. Two leaders had taken her research course, and she had encouraged them to conduct their study proposal here at the hospital. Once that was done, Cheryl volunteered her time and expertise to help with analysis of the qualitative nursing study. She heard about our magnet feedback and shared interest in partnering with us to develop a nursing research foundation with sustainability. So we were very fortunate that 7 months later, we were able to bring Cheryl on board with us, working 20% of her time, and then have a contract buyout relationship in 2018 for 50% of her time. So the road from research to EBP, how did we get here? EBP and research are a two-way street. If evidence exists, then we're called to put it into practice. If evidence is not there, then we're called to conduct research. Many are unfamiliar with the differences between QI, EBP, and research, overlooking the critical part each of them plays in the success of these processes. Each one is equally important and plays a role in which clinicians can investigate, create, and implement best practices in patient care. So along this road, there were several influences that led us to where we are. I'd like to speak to 4 key areas that influenced us on our journey to research, from research to EBP and back again. The first one is academics. As part of our beginning partnership, Cheryl paired undergraduate student nurses in her research class with clinicians at CCH. She called it Smart Partnership. Students were learning about EBP in the classroom, and clinicians here were making changes in policy and procedures based on evidence. The partnership was to support and educate both sides in working on a specific project which would benefit CCH and the students. We were also being faced with increasing requests for students to complete DMP capstone projects at Chester County Hospital. We found the combination of these 2 events led us to believe that we needed to learn more than we already knew about EBP.
In addition to these influences, on my end, I was teaching research at both the undergrad and graduate levels. And I remembered back, as I wrote my courses, I remembered how much I disliked research in my undergrad education. And probably there are several of you raising your hands right now to say, yeah, I didn't like it so much either. And it's ironic because obviously now I love it. But I wanted to teach it differently. I did not want to teach it the way that I had been taught. And I had already included a section on EBP, but it was really quite small, and it truly wasn't big enough. And I would come to learn even more just how big it needed to be in terms of our research program.
So the second key area was our focus on Magnet and the Magnet document. We completed the writing of NK1, which is New Knowledge 1, on a research study that was completed at Chester County Hospital for our Magnet redesignation, when we learned that we could also be helpful with writing 2 other stories, that of NK2 and NK3. NK2 addresses the dissemination of nursing research findings to both internal and external audiences, while NK3 addresses the use of EBP findings in a nurse's practice to both implement a new practice and to revise an existing practice. Through this, we learned about the importance not only of research to the Magnet process, but also of EBP. In practice, as mentioned on the previous slide, we examined the interrelationship between QI, EBP, and research. And finally, through experiences, we were fortunate to hear Dr. Nancy Albert from Cleveland Clinic speak about the nursing research program there at the 2015 Penn Nursing Research Conference, and then followed by Dr. Bernadette Melnick to hear her address the work that her group at Ohio State University had done with EBP at the research conference the following year in 2016. We were members of the planning committee for the programs and attended both conferences with our CNO. These 2 presentations inspired us to move forward with new ideas and plans with the support of our CNO. In addition to these experiences, we were also in touch with many of our colleagues who were EBP champions within the healthcare system using a variety of models, from Johns Hopkins to Knowledge to Action to Melnick and Feinout Overholt's ARC model. So all of these influences led us here. We attended a week-long EBP immersion in Columbus, Ohio at the then Center for Transdisciplinary EBP and what is now known as the Helene Fold Institute in May of 2017, supported both by the hospital and our CNO. So to briefly describe our experience, I would use 3 words: full, fast, and fun. They enter 3 specialty tracks within their course, that of mentor, academic, and leadership. I took the leadership track and focused on how to leverage an organization's strengths to build, grow, and sustain an EBP culture.
And I took the academic track, which really helped to foster my knowledge to bring back to the university.
5 days of learning and applying the 7 steps of evidence-based practice, homework in the evenings, a mind-changing event, and it will forever be stuck in my head, what's the evidence? Although we can't recount all of our experiences and knowledge gained from that week, we want to provide a little that focuses on our journey. As a review, I like the analogy of a three-legged stool when we're talking about evidence-based practice. EBP is a problem-solving approach to clinical practice that takes the best evidence, the one leg, in combination with a clinician's expertise, the second leg, as well as the patient's preferences and values to make decisions about the type of care that is provided. Chester County Hospital is part of a large system, but it's not identical to any of the other entities. For example, we have different clinical expertise. We're a community hospital, and we're small.
As we discussed before, we embarked on this EBP journey after the immersion in May of 2017. And some of the information we gained through that immersion were these 7 basic steps that really provided the backbone of our knowledge during that week. So there are other EBP frameworks, and other frameworks are also used within the University of Pennsylvania Health System. But after the immersion and viewing the other models and meeting with our CNO, we decided that Chester County would use this model in lieu of our present Iowa model. We realized EBP and research are inextricably linked, and that in order to really have EBP, there must be evidence that can be utilized. And one must understand, that is, critically appraise the research, the key elements of design and meaning, to determine the quality of the work, and if it can be reasonably applied in your practice. This is a step that often I think people skip. Someone may say, we find one article and we're going to go this way. But we really need to look at all of the literature and all of the evidence. Although we've worked with clinicians through all 7 steps, and I teach all 7 of these steps, we're going to focus a little later in this presentation on how a strong foundation for this work is crucial to the development of our program. So after returning from the immersion, we began work to structure our research and EBP program. What you're seeing here is our charter for the Research and EBP Council. Of note is the fact that we made a decision to put research and EBP together. That's not consistent throughout the health system as well, and just in talking with other people at other institutions, everyone has a slightly different view of this. So this was an evolving process that we went through beginning in the second half of 2017 after the immersion, and it went into early 2018. And I'm going to take apart some of the pieces of this charter to speak to them. The first one is the mission statement. So to establish and sustain research and EBP practice priorities for the organization. Well, that was initially driven by our magnet designation and about the needs that were identified at the end of the magnet designation. The second was to support the environment and using the ARC model, so the Advancing Research and Clinical Practice Through Close Collaboration model by Melnick and Feinout-Overholt. We wanted a pathway, and as we learned about this in the week that we spent in the immersion, we felt more and more that it really fit. And the other piece that we learned during the immersion was how research and EBP could fit into the organization and be a framework for almost all of it, and not need to just focus at the bedside. Everyone should be asking, as Cindy said, where's the evidence? You know, what does the evidence say? One of the key pieces that we also connected with in the ARC model was the strategy of developing a critical mass of EBP mentors who are skilled in both EBP care and knowledgeable about the individual and organizational change. And we felt that would be a huge positive for our organization. In terms of our business impact and vision, we have a 4-fold vision, as you can see on the slide. And we've managed this strategically. And when I say that, I mean that we could have opened the floodgates wide and said, okay, we need more research, we need to build more research, we want more EBP, and let anyone who wished to bring in a project do so or generate a project from here. But we wanted to do this strategically. We're a community hospital. We have a small research and EBP staff, and we wanted to be able to sustain this. So we didn't want to create something that we could not sustain. What we also noted, though, as we looked at the impact and the vision, is that it is in line with not only Chester County Hospital's vision, but we're also mimicking the Institute for Healthcare Improvement's quadruple aim, which is used across the hospital and the system. So what is the scope of our council? We found that we wanted it to be sort of a funnel. We wanted the ability to review all potential EBP, QI, or research projects in the form of PICO questions. So for those who may not be familiar with it, it's population, intervention, comparison, outcome, and time. So it is the question that helps someone get into the literature. It's not your final project, but it's the question that helps you look at the evidence and decide what's there. Is there enough evidence for what you're talking about? The council would then review this. They would look at it if the projects were deemed to be quality improvement. We had already developed a relationship with Clinical Excellence QI Committee in which we sit at their monthly meetings, and they have representatives who sit at our monthly meetings. And we call this council for short REC. So if I refer to it in the future, you know that's our Research and Evidence-Based Practice Council. And cooperatively with them, they would bring us any information about EBP or research projects, and we would forward anything that may be QI. Finally, we would get approval from the appropriate administrator on all the EBP and research projects, and then the projects would either go to an EBP mentor and the remainder of our council, or if it was research, it would go to the research department and the IRB. Of note, the council was formed March 1st, 2018, so we're coming up on 1 year of having the council. It feels like a whole lot more, but it's just its first birthday coming up. In terms of council goals, we had 4 basic ones. The first being partnerships, and I think that may be one of the most important ones. We had developed several. We had clearly developed a beginning partnership with the Fold and an ongoing partnership now with them. We had begun to explore information about research program development from the Cleveland Clinic through hearing presentations, reading a book that they had published, and then actually making connections with one of their nurse scientists. And then the partnership with Westchester University was well underway. My previous work with 2 of the directors here on their qualitative work. We have interest from different departments now, which is really exciting. We have a kinesiology professor who is conducting research here with a grad student that I'll mention later. We just had an intern from the Masters in Public Administration Department complete work with us. And we have a pending project with a chemistry professor and our pharmacy department. All of our members, in terms of basic education, we felt everybody needed to speak the same language. EBP was out there, but was everybody understanding EBP in the same way? And so we thought about this. We knew we couldn't send all of our members immediately for an immersion, but we had talked with people out at the Fold during our week and then looked at different ideas and decided that what we would do is use their one of their MOOCs that was online at OSU for EBP, and it was a beginning education, not the end, but it was a beginning, and I'll show you a slide coming up about this. Our hope is that we will bring the Fold on site here for an immersion through some grant funding. Supporting the culture of inquiry. Remember, that was step 0. We're going to keep going back to that. The big one here is supporting that employees can ask questions. You know, not every place is comfortable with the ability to ask a question. Why do we do this? You know, why aren't we doing that? We want people to ask that, and we've been trying to foster that as much as we can. Cindy and I also go to multiple meetings. We make sure there's a lot of face time for our rec, and we're trying to make things more accessible, so we've begun working on an intranet and a database, and that'll go throughout this year. So as part of the charter, we wanted a way to measure our goals and therefore develop these metrics. And they'll change with coming years, but at this time, we're predominantly focused on numbers 3 and 4. Okay, so coordinating the resources, making this more accessible, and then the database. But we're not losing sight of grant development so that we can continue the education and deepen it further. We also did something that we learned about very clearly in the immersion, which is finding your stakeholders, finding the key stakeholders and meeting with them. And again, using that word, very strategic. So once the charter was completed, we sought meetings with all of these key stakeholders. We showed them our charter. We showed them the scope of the council. They particularly like the moving parts. That was some animation. As an academic, I know that sometimes I put my audience to sleep if I don't have something moving on the screen, so that was a help. But we showed them this and asked for their support and eventually their buy-in. And we were incredibly pleased that we got both. And they were interested in this and brought us information to make changes and how we could really be successful. The final piece of the charter is our recruitment, our member recruitment. And what you're seeing on the screen, these two lists, are the representatives we have right now. We started out small. We started out with a core council, and then we asked for input. We said, well, who else should sit on this council? And should they be regular members, or should we pull them in when we have projects that are specific to those areas? So we were looking to build a critical mass of members. Two things happened. One is that people asked us to join the committee. Now, I don't know about you and your organizations, but I know at the university, I'm on more committees, and many of my colleagues are as well. Usually people don't volunteer for more committees and more meetings, and I think the same is true of hospitals. But people were really excited to work with us, which just really ignited the flame under us as well. The other piece is that we learned during the immersion that don't focus on the people who are not following right now. Don't focus on them that are all the way at the other end of the spectrum. Focus on the people who are engaged, who are interested, who are excited, and you can build that critical mass, and it'll get to a tipping point where you'll be able to pull in many more people, and that's exactly what we did. It is an interprofessional group, as you can see, and the one thing that we did face was a barrier in terms of the timing of the meetings because everybody's schedules were different. So recently we just made a decision that we'd have monthly meetings, but they'd be at a different time and they would alternate. So for instance, our meeting this month is on Thursday at 9 a.m. and then for next month it'll be Tuesday at 3 p.m. so that within a 2-month period we can pretty much hit everybody. This is what I mentioned before. This is the MOOC, the Massive Open Online Course out of OSU on evidence-based practice. And we opened this for everyone on our council, and we utilized the tools that were here and then went through them during our meetings to make sure that people were clear.
So we'd like to share some of the successes that team members have had here in evidence-based practice and research, and we'll share 3 clinical and 1 academic. So when we started working with Cheryl, our research scientist, many nurses had great passionate questions in their mind. I wonder if, or why do we do this? And so what you're looking at here is our nursing research timeline that we started in 2015, trying to capture the stages of the work that was in process, and then also the people and what their projects were. Some projects had been started, and others required initiation, coaching, and mentoring. For example, 2 direct care nurses conducted a research study regarding the management of neonatal abstinence syndrome with prone positioning. And Cheryl's pointing out where they're captured on this timeline. One informatics specialist nurse who was conducting her DMP capstone on exploring patients' experiences, expectations, and satisfaction with point-of-care documentation. And then an how about an interventional radiology nurse who wanted to conduct the first randomized controlled study by a frontline nurse at Chester County Hospital, looking at aromatherapy in pre-procedural patients prior to biopsies and their stress level. So the first example of an EBP mentor is Kathy Hubbard. We would describe Kathy as a rock star and role model of EBP implementation. When you run into her in the hallway, she always has a new idea, if not 2. She's a frontline nurse in perioperative care, and she is part of the perioperative unit council. And this council was troubled by the incidence of postoperative nausea and vomiting, PONV. Kathy took on the work of doing a retrospective chart review, and our incidence was less than the national average at the time of 30%. We were 23%, but this unit council group was not satisfied. They viewed that any postoperative nausea and vomiting that could be prevented should be. They wondered if a pre-op risk assessment of developing postoperative nausea and vomiting could make a difference in our incidence. So promoting a culture of inquiry, Kathy led by example. She gathered support of key stakeholders such as anesthesia, our chief nursing officer, ambulatory care nursing. Kathy developed a PICO question and conducted a literature search. She found the APFEL risk assessment tool, which is valid and reliable. Real simple, 4 predictors: female, history of motion sickness or PONV, non-smoker, or a history of needing postoperative opioids. You get 1 point for each yes answer, total the points, and then you're rated at low, moderate, or high risk. With the support of the stakeholders and knowing what our incidence was at the time, Kathy got the green light to provide education for use and develop the screening process, use of the APFEL risk assessment tool. Patients were screened for a 3-month period, and paper screening tool was placed on the patient's charts for anesthesia to review prior to surgery. It was the provider's choice on what to do with that information, such as considering administering 2 IV antibiotics, how about antiemetics, prior to surgery. Maybe antibiotics too, I don't know, but antiemetics prior to surgery. Kathy utilized the ARC model, Advancing Research and Clinical Practice with Close Collaboration. She used the model and applied it with stakeholder support. And the next. And what she found when she looked at the 3 months of patients that were being screened was that there was improved patient outcomes because our postoperative nausea and vomiting incidence went from 23% down to 7.5%. What we didn't realize is that we thought, okay, we've got it made now, but a new barrier was identified. And using the paper form was no longer feasible because we had a new electronic medical record that was put into place, and so it really changed our process. And we're having discussions here and across the system looking for ways to implement the utilization of a risk assessment tool within our electronic system.
I think the one big piece about this experience with EBP and Chester County is that in looking at this model, we did not expect to go from EBP implementation to improve patient outcomes back to potential barriers. So if anything, we were very curious at the process and thought, well, perhaps this is more cyclic in nature. So, once you've got evidence, you put it into practice, it's really not static. And so we need to be ever vigilant that we have the tools that clinicians need to be able to use best practice. The second example is a pragmatic clinical trial that is ongoing now. The PI is a university professor from Penn State. The project is funded by the National Institute of Aging, and she selected Chester County as well as other Penn Health System entities. And one of the big pieces about this project, she's looking at a real-world test of the efficacy of family-centered, function-focused care. A mouthful, definitely, on patient and caregivers. And we're looking at those caregivers that are those patients, rather, who are community dwelling, and they have mild to moderate dementia, but have been hospitalized, and they have a caregiver. And the importance of this project is not only, obviously, the importance with our growing dementia population, but that we want to work with research investigators that bring value to Chester County, to our patients, to our community, as well as bringing that to the science. So in this project, we found that it brings value not only to Chester County Hospital in the form of a potential decrease of readmissions, but also to the researchers as well as the clinicians here at the hospital, to patients and caregivers, and then the information itself being valuable to society at large. And in many ways, if you look at this again mirrors the quadruple aim. Our third example is from West Chester University, and it's a university professor and her grad students are doing a project on newly diagnosed cancer patients. And the intervention is a supervised exercise, or a series of supervised exercise sessions. And they're looking at these exercise sessions prior to chemotherapy and whether there's an impact on quality of life and a decrease in cancer-related fatigue. Although this isn't the first study conducted at Chester County Hospital by a West Chester University professor, it is the first partnership with the university since our REC was established. And it's also outside the Department of Nursing. We've had studies come out of the Department of Nursing at West Chester University here at the hospital. In terms of value, again, this academic practice partnership has broad value, bringing that to numerous people. So the researchers in terms of exercise physiology and physical therapists here, the hospital in the possibility that patients will tolerate chemo, which obviously leads over into patients, but then also knowledge. So the broad knowledge that is created from these studies. In academia, I also did some work after the immersion. So after the immersion, I came back and proposed that we scaffold research and EBP content within our graduate programs, and that would be our master's and our DNP. In the summer of 2017, a couple months later, we rewrote the grad research and EBP courses and did exactly that. We scaffolded them. Then we entered into discussions about scaffolding from bachelor's all the way up to DNP. So the following summer, we rewrote the undergrad research and EBP courses and feel that we are in a good place to be able to move forward with the knowledge and our students. So I mentioned before that we talked about these 7 steps. And by the way, for those of you who are like, look quickly at the top or to the right side of the screen before, you're like, there are 6 steps. But it starts at 0, okay? 7 steps. Although there's 7, we've worked with people over all of those 7 steps in many stages of their work. Our goal this past year and moving forward really was to create and now sustain a culture of inquiry because it is the foundation of EBP and research. Okay, who did we want to create this with? Most definitely our research and EBP council members, our REC members. Any key catalysts within the institution. We want to make sure we have continued face time with clinicians, administrators, and staff. And then we wanted to do something else. We wanted to figure out a way to continue stoking this culture of inquiry, but also making a virtual space for recognition. So in some ways, we not only covered step 0, but step 6. Step 6 is dissemination. We wanted to create a space for this at the hospital. And so what we did was create virtual poster presentations. The process was we created a video on a smartphone, not anything really high-tech. We created a QR code, and on the left side of your screen, show you. All right, doesn't want to show, oh, there it is. Okay, left side of your screen, you can see down the bottom. So for those of you who are not familiar with this, it's a 2-dimensional matrix code, the black and white square, and it was actually originally produced to improve efficiency in Japanese car plants, car manufacturing plants. But these codes are all over the place now, and you know they'll say, oh, read this code. Well, for years you had to download apps to be able to read it. Now with an iPhone or an Android, you can just basically open the camera and hover over this so that it's in your viewfinder, and it will read the code. And what it'll do is redirect the viewer to a particular object or a place displaying specific information. So we saw this as a tool that we could employ the use of mobile-based micro-learning to ignite and sustain a culture of inquiry by sharing this knowledge on demand. If you think about times when things are scheduled, information being shared with staff, it's difficult because everyone's busy. But this was something that could happen no matter when or where. We copied the left side of this screen, and they were posters, and they were put in all of the units in the hospital in provider areas as well as public areas. And then outside our library, the poster that goes with this that Kathy Hubbard presented at a conference was there, along with a copy of this flyer. Right now, we're working on getting continuing education credits for those who view the poster, view the video, and then take a couple question quiz online. And that should be coming through shortly. This next one, we did have a video we actually recorded. This is Kathy Hubbard. It's just under 2 minutes, but we had some challenges with audio. So we're just going to tell you a little bit about it. And when Cindy and I talked about what this looked like, the first word that came to our mind is passion. And so if you could see this video, you would see how incredibly passionate Kathy is about this and why she is one of our strong EBP mentors and just a catalyst. And she shared with us early on that the reason that this was such a hot topic was not only her care for the patient, but she could identify with the patient. As she put it, she's a puker. And so she knew that post-op nausea and vomiting was not a good thing no matter when it happened. The one thing that I want to tell you about this video is it's informal. There was no script. We sat down in a conference room, and she really just talked about her passion and about what she did, what the project was, and how excited she was to tell everybody about it. So hopefully next time we'll be able to show you one of those videos. So in review, we want to talk about where we've been and where we're going. And you may look at this and think, okay, so why is there a tree on the screen? We like the tree to think about our roots, so the foundation, and then the tree growing strong and tall, and then becoming fruitful. So I'm going to talk a little bit about where we've been. So in 2017, we were building that foundation. We had made a partnership with then CTEP, now the Fold Institute. We had gained information from the Cleveland Clinic and their model, and we were really ready to go. And we had attended the immersion at Fold. In 2018, we started our charter, and we created the REC, the council, and as you can see, that's the backbone of our work. That is the tree trunk. We continued the partnerships that we had. We were in the planning phase. We were looking at foundational pillars, strategic plans. We were looking at the potential for intranet and database and what personnel we needed. And also in 2018, we returned to Ohio State as co-facilitators for another immersion. And although we were helping the facilitators to teach new people to be mentors, we also gained an incredible amount of information once again. And then in 2019, we're continuing those partnerships. We'll be celebrating, as I mentioned, 1 year of our REC. We're focusing on growing and nurturing through grants and site immersions, and also a focus on the intranet and the database personnel. In addition to coming back for a third immersion as facilitators this year, and I know bringing probably more back than we had before. So we've continued to fan the flames of that culture of inquiry through the use of the QR codes. We actually have a column coming out in Worldviews on that project of QR codes. We'll continue to expand it in 2019 by adding the continuing education credits to the posters. But as we've done before, we're going to move forward in a very, very specific manner.
So not to be overwhelmed by everything to be done, as we were asked multiple times at the immersion and multiple times from Lynn Gallagher Ford since, how do you eat an elephant? Strategically, one bite at a time. And Lynn is the one that shared the one bite at a time, and Cheryl and I have added the strategic portion of it. Thank you so much for your time and for listening, and sure appreciate your participation. And now we'll look at questions, if anyone has questions.
We absolutely gotten some questions, Cindy and Cheryl. Thank you so much for that incredible presentation. So, Carrie Quinn wants to know, are you able to access how often the QR codes are accessed? Are you able to assess how often the QR codes are accessed in your
Yes,
QR code?
we can. I'm sorry. We actually can. What we did was, the QR code creators are all over the internet. There are free ones, but there's also ones that charge. The ones often don't track the information, but what we did was we went into bit.ly, B-I-T-L-Y, to shorten the URL for our videos, and that will track it. So we're able to tell how many hits we get, when we promote it, how well that responds. So yes, you can do that.
Fantastic. Let's see.
Looks like some folks are typing questions here, so let's just see what we've got.
Carrie wants to know, she said she loves the advice to focus on the people who are engaged now and develop a critical mass. The others will come along. Simon Sinek. Yep, absolutely. So,
yeah, and we really did find that. But that was, I still remember the video from the immersion, and we saw it in action, which was just so cool to watch here.
That's really cool. I have a question for you guys. So it has been an amazing, amazing year. Like you, I can't believe that you're only coming up on your 1-year anniversary because like you have this working like a well-oiled machine. But do you have what was your biggest aha moment through this whole last year's journey? Was there one kind of biggest aha?
Let me think. I think the intersection with EBP and research had to be the biggest aha moment. You know, coming out of a PhD program that was research focused, that was where I was headed. And I think a variety of experiences here at Chester County, the influence of teaching in a DNP program, and really looking at that. I think that was my biggest aha moment, and how there are no strong barriers between research, EBP, and QI. And the more that I think we allowed it to look fluid, the further we got.
And along with that, we're seeing some decrease in visual anxiety when you mention the word research here in the institute.
Awesome.
But people are like, they step up to the plate to want to take evidence and put it into practice. And then we have people who really are interested in research. So it's been fun for us to find that balance. And as we said in the presentation, we realized we thought we knew what evidence-based practice was, but for me personally, I knew I needed to learn more. So I agree with Cheryl that we realized that to focus solely on research was not going to be the appropriate match for our culture here.
Very good. There's some people typing. So waiting for those comments or questions to pop up. Let's see. Okay, so Jill Arzeman has a comment. We found that the DNP and PhD partnership essential in guiding nurses toward either EBP or research. It depends. Burning question. And Amy says, Amy Reddick from OSU says, your interdisciplinary focus was beautifully laid out. Was there work that you did to engage academic departments?
So so academic on the Westchester University side, or talking about the departments here at the hospital?
Amy's typing a clarification.
In general, with academics. Okay. So with academics, what we did first is, in order for me to have the setup that I do over the past 2 years, I had to go through our Office of Sponsored Research. So they knew sort of about this 50-50 partnership. And therefore, when people were coming to them, when professors from various departments would come to them about, I want to do a project and this and that, Laura, one of the key people in the department, would shuffle them over to me, and if it felt like it would be a good match. So that was one way. And then another way was kind of through word of mouth. People that I knew. My position at the university is through the College of Health Sciences, and so letting people know what I was doing, and hey, if you're interested, come talk to me. And that has continued to happen when they ask me questions about what I'm doing. So I try to bring people in. I met a health department faculty member a couple weeks ago at a workshop, and told me what his interest was, what he'd love to do, and I said, okay, we need to set up a time to come in and talk. So it's really been exciting to see the two sides interested.
And we have a colleague here that is in the MPH program at Westchester, Judy Suska, and she has brought different people to our table to discuss the possibility of doing projects here or internships here. So the networking is getting broader for us.
Very nice. It's cool to see your good work in shepherding people to the opportunity continue to grow and explode. Amy says, I love how that relationship is building. Do you suspect that you may be able to leverage students in academic programs? If so, what would that look like?
So I'm seeing her, and then she said you were answering my question.
Oh, very
I'm not sure if I answered that already, but I think that one of the pieces is sort of like I talk with different people today. I reached out to 2 different professors, somebody in math and statistics and someone in computer science, and said, hey, we've had interns before. Do you have any students who are interested in internship? And it does 2 things. One, I love the infusion of having the students there, here rather, as well as at the university, that we can learn from them and they can learn from us, but also with a very small budget and not a lot of us, we can get help. So we were fortunate last year to have a partnership in math and statistics, and we had a grad student who did his internship with us and helped us tremendously with analyzing data for some of our studies. So that kind of partnership we feel like benefits both sides.
Beautiful. Beautiful. So, well, we can't thank you guys enough for sharing your time, your insight, your journey. And again, we wish you nothing but the best, but see nothing but incredible things in the future for you.